It is my pleasure to introduce our next speaker. Harry Ong is one of the neuro-ophthalmologists here at UTHA. He is a neuro-ophthalmologist who came via the path of neurology. He did his neurology at Penn and then did his neuro-ophthalmology fellowship at Penn also. He is splitting some of his time to come over and see patients in the Pediatric Pavilion, and today he's going to talk to us about Pseudotumor cerebri.
Wow, I was not expecting an introduction. Thank you. It's my pleasure to be here. Thank you for the invite. And I know that basically right now, I'm the only few bodies that's standing between you and the warm weather, so we'll try to speed it up and get it on. So I'm going to give you a brief introduction about this disease entity, pseudotumor cerebri syndrome, which can cause headache as well. Okay, and then the question in my field is often, is there a papilledema or not? Is it this way? Got it. Okay. And I have no relevant financial relationship to disclose. So the objective of this talk is basically three. So one is try to review what is pseudotumor cerebri syndrome, the primary pseudotumor cerebri syndrome, which is often also known as the idiopathic intracranial hypertension. But there's also the secondary pseudotumor cerebri syndromes caused by medications or systemic disease. And also I'll highlight a classic presenting feature of this syndrome, and then also discuss about potential next steps of what to do. So what is pseudotumor cerebri syndrome? The key feature of this syndrome is actually these four things which in order to fit the diagnosis. So one is there should be a presence of papilledema and or sixth nerve palsy, so which is causing the sort of a horizontal double visions. And two, the neuronal imaging should actually reveal normal brain parenchyma, meaning that there should be no brain tumors or any signs of hydrocephalus, like a aqueduct stenosis or something that's causing hydrocephalus or increased pressure. And three, it had to be proven by lumbar puncture to have elevated opening pressures. And for adults, it's 25. If the kid is not sedated and not obese, it's also 25, greater than 25. But if they're sedated and they're obese, actually the number goes up to 28. And they're borderline high if they're between 20 to 28. And then the next point is actually normal spinal fluid constituents. So they should have normal chemistry with no signs of sort of inflammation or infection, because that can also cause increased pressure. So then you're going to be treating that instead of sort of treating the high pressure. So like I was alluding to, for pseudotumor cerebri syndrome, there's a primary form, which is what we often also know about, the idiopathic intracranial hypertension. And this is where the association with the weight gain is highly relevant. And there's also the secondary form, which is related to medications, cerebral venous abnormalities, and medical condition. And I'll talk about more in the case presentations. So the demographic of IIH, I'm just going to delve a little bit more. So before puberty, actually, boys and girls have similar prevalence. So there is no difference in terms of like have more prevalence in girl. And actually, there's not a clear association with obesity. So a young kid coming, a prepubertal boy coming to you for like potential that is possible. But then when after puberty, that's where the sort of what we are commonly are more aware of or taught is basically the pseudotumor highly prevalent in young, obese females, which much higher, and a strong association with obesity. And unfortunately, in America, about 22% of children under the age of 18 are now obese or overweight. So that is increasing. But the prevalence of IIH actually, as an overall, is about 1 per 100,000. And then in the female, in a young post-pubertal, it's about 4 to 20 per 100K. So it's still a very rare disease. So workup of pseudotumor. So if you're suspecting that and it has been sort of found to have papilledema and or sixth nerve palsy, the next thing is getting an MRI brain with and without an MRV, so or MR head venogram. And what we're trying to look for is, like I alluded to, a normal brain parenchyma and no signs of structural lesion causing hydrocephalus. And also, sometimes these sort of MRI can give us sort of radiographic clues about potential raised ICP, such as, actually I don't have a pointer, like the empty cella, so basically where the cells have the pituitary that kind of push underneath. And then otherwise, you can also have these like tortuous optic nerve, or the optic nerve sheaths are enlarged, or the posterior globes are being flattening. So these are the four sort of common radiographic signs. And then on the venogram, you can also see stenosis of the transverse sinus, not thrombosis. I'm talking about stenosis that they often talk about. But one caveat to these radiographic findings that they could be non-specific. So it doesn't mean that if you have it, the patient automatically have pseudotumor cerebri syndrome. It just sort of points to potentially. And often these radiographic findings actually persist even if the patient may have previously had papilledema or high ICP, they're treated, but these radiographic findings does not reverse. So it actually stay for years. So it could be either a previous papilledema that resolved or just non-specific findings. And afterward, you kind of work with the lumbar puncture to get opening pressure, cell count, and chemistry. All right, so let's go through a case presentation. So if you have a 16-year-old healthy teen presenting with increasing headache to your office, so what do you ask next? So the associated symptom that you often ask is headaches. Like Dr. Pavitt was alluding to, is it worse in the morning or laying down? Is there a positional component? Because if you imagine there's a raised ICP, it'll be worse when they're supine rather than sitting up or standing up. And also they have often an associated symptom, which is pulsatile tinnitus. So this is actually a whooshing noise, not a ringing noise. So it's actually a sorry, I'm not doing it very well, but it's just sort of whooshing, like synchronizing with your heartbeats. And there's also a phenomenon called transient visual obscuration, which is a transient sort of blackening of their visions, very quick. It's a few seconds. And then they, especially with the positional change, such as bending over or sitting up, but without other pre-syncopal syndrome. They're not like not lightheaded, it's just a transient vision loss and then comes back again. And then also if you have any horizontal double visions. Out of these, the headaches is the most common but not specific symptom. Pulsatile tinnitus is one of the more specific symptoms, and whereas if you're having daily TVO is actually the most concerning. That potentially means that the optic nerve is swollen and having this transient ischemia, and then sort of causing the TVOs and then relief, and then comes back. So the relevant history, so if you're suspecting a pseudotumor, number one question you always ask, especially for postpubertal and females, it'll be weight gain, weight gain, weight gain. Because as you can see in this sort of prevalence epidemiological studies, that they're now about above 20% of the kids are obese or overweight, and then it's increasing as they age. And then the second questions are these medications and systemic illnesses that I was talking to that can cause secondary pseudotumor cerebri syndrome. So number one is basically tetracycline derivatives, so like doxycycline, monocycline. Again, the duration in the literature is not very clear, but we're talking about more like months, not like a week course for antibiotics for pneumonia, but it's more like months for usually in the use of like dermatology. Vitamin A or retinoids derivatives often can be used in like cancers for AMLs and also for acne. So even topicals, there are case reports that can cause the pseudotumor cerebri syndrome. And then exogenous growth hormones or high-level levothyroxine, lithium, and then corticosteroid withdrawal, and then cyclosporine. And there's actually a case report, the last part, the Mirena IUD, case reports and also large sort of case control studies that show that there may be association higher, about like twofold in risk of Mirena IUD leading to pseudotumor cerebri syndrome. And lastly, about systemic diseases. So you asked about anemia, Addison disease, which is kind of equivalent to the steroid withdrawal state, renal dysfunction, uremia, hypercapnia, and hypercoagulable states. So what can you do in terms of, from your pediatric perspective, pediatrician's perspective? So first is actually check the blood pressure. In a lot of time, actually, the hypertensive crisis can present as bilateral dysedema and also having headaches. I just have 2 cases in my clinics coming in with undiagnosed hypertensions. So that could be one thing to check first. And of course, check the weight and calculate not BME, BMI, to see if there's changes in their growth. And that's also, if you can, perform neural exams and if possible, fundus exam. So if in your assessment that the exam for the neuro exam is normal, there's no visual complaints or decreased visual acuity and no other red flags as indicated by Dr. Pavitt, then you can refer to pediatric ophthalmology or neuro-ophthalmology or neurology. The reason I put all there is because there's wait time to get into our thing. So if your suspicion is lower, then you can help triage, because pediatric ophthalmologists or ophthalmologists can often help us diagnose whether papilledema or not, and then can start to initiate initiate workup, like the MRIs as well. But if you really notice that there is an abnormal neuroexam, like a focal neurological deficit, a clear disc edema that you can notice on your fundus exam, or a new onset sixth nerve palsy or horizontal binocular double vision, then they really need emergent imaging, MRI, MRV, because one, you want to make sure there's no tumor, because then that help us. The next step is basically getting a lumbar puncture so we can get the treatment started as soon as possible. And talking about treatment, so there are medical arms and also surgical arms. So in the medical therapies, the first time is Diamox or acetazolamide. And unfortunately, that has a lot of often have a lot of side effect because it tastes nasty and it makes soda taste nasty. But it is a first line, it works by lowering the CSF pressures. And then there's other second lines such as Lasix or topiramate. And there are, unfortunately, a few cases where there are actually malignant pseudotumor cerebri syndrome where they're actually having a rapid vision loss. And that's where the surgical option comes in to try to alleviate that pressures ASAP. So one is actually optic nerve sheath fenestration or CSF diversion, where we work with the neurosurgeons. And then there's actually a new kit in the sort of the surgical realm is venous sinus stenting, which is actually opening up that transverse sinus and increasing the sort of the CSF outflow. But the drawback is basically once you put that stent in, then the patient has to be on antiplatelet for life. So with that, that concludes my quick introduction about pseudotumor cerebri syndrome, and I will be open up for any questions. Oh, thank you.
So it is my understanding that there is a lot of debate in the world of ophthalmology as to whether or not optic nerve sheath fenestration is something that should or should not be done. I've heard arguments that it's dangerous and risky and causes blindness. I've heard arguments that in the setting of CSF diversion in a fulminant case that it really can be the vision-saving part of that procedure. And I was just curious if you have any insight into why there seems to be such a diverse perspective on that.
Thank you for the question. That's an excellent question. So I guess I was trained in the world where optic nerve sheath fenestration is actually the go-to route, especially if there's a vision loss. But I have seen cases because when you are doing the optic nerve sheath fenestration, sometimes you could have a little bit of pull or tugging on the optic nerve. And there are cases of having like CRAO, like basically artery occlusions, like a major complication that it actually comes out like blind in that eye. So that is a risk that you have to think about. But I was trained basically if the main complaint from the pseudotumor cerebri syndrome is vision loss, optic nerve sheath fenestration is the first step because that can really reverse the vision or temporize the vision loss. Whereas if you have vision loss with headaches, then VP shunts could be the other route or the long term. Because optic nerve sheath fenestration is a temporizing measure. It's not a long term because after a while the pressure equilibrates and that valve will close. The fenestration will close. So, and long term, you do have to. It just buys you time to either get the Diamox on board to start or get the VP shunt in place. Yes, Dr. Papp.
I'm going to ask you another controversial question. I was wondering if you could just share your insights on IIH without papilledema and your thoughts about all of that.
I knew someone's going to ask that soon. Yes, there is a controversial. So we just had one of our a premier speakers that talked to us, Nancy Newman, came to us and talked about. So IIH without papilledema is an entity, and it's so one thing is basically if you have IIH without papilledema, so they don't have risk for vision loss. So it is a recognized entity, but they don't have vision loss. So the treatment actually plan kind of change. So from what I was taught and learned is basically that now falls more into a collaboration with the neurology. They're treating as if it's a sort of headache syndrome now. So I think you still use Diamox, you can use Topamax, more likely with Topamax, but you don't do serial LP to kind of measure that opening pressure. You just kind of treat it symptomatically, which is very hard sometimes because it's just really hard to manage that. And then the question then is are these patients if they truly does not have papilledema ever and just have IH without papilledema and based on opening pressures and then also the radiographic finding, they're not at increased risk to have papilledema compared to other people. So it's not, so then it doesn't mean that they have to be seen sort of ophthalmologist like every 3 months or stuff like that, but they should see ophthalmology at least every year to make sure they're not developing papilledema. So I don't know if I answered that question, but it is an entity, yeah. Yes.
So how do you distinguish the visual symptoms you're talking about from floaters?
Sure. The question is, how would you distinguish the floater from the visual symptom? Are you referring to the transient visual obscurations? Yeah. So the transient visual obscuration actually is sort of a complete, it's like a transient, actually there's like a sort of closing, blackening of your visions. Whereas floaters doesn't really obscure your vision. You see kind of like a dust kind of floating around. And that kind of move as you move your head, and then just kind of persists more than seconds. And then the other question maybe you might relate to, how do you distinguish from a visual aura? Because people can have tunneling vision from migraines and stuff like that. It's more the duration. So TVOs are seconds. So they're very brief with positional change, whereas the aura, visual aura, like tunneling or these like scintillating scotoma, they're minutes, like greater than 5 minutes.
I don't have a microphone, but
I can repeat it.
question. What's the role of OCT in following these patients, or is there a role for that?
Yeah, that's an excellent question. The question was, what's the role of OCT in following these patients? So with these advances of our technology, we have been following them not only with a visual field, but also OCT, because the question most of the time, if they're swollen, it's pretty easy, then you just treat it. It's basically, when do you take those medication off, or those patients where they're borderline, they have papilledema and also pseudopapilledema which is out of this talk, but like drusens, or they just have anomalous optic nerve. So OCT really help us have an in-depth look at the optic nerve and measure them. And the other ideas about OCT that's really helpful is when the optic nerves start to come down, you want to know, is the swelling coming down is because your treatment's working, so then optic nerve swelling, the ICP is lowering, or the nerves are dying. Atrophy, exactly. If the nerve is atrophy, the swelling will go down too. So the OCT actually let us look at the ganglion cells, which form the fibers for the optic nerve. So then we can see if the ganglion cell layers are normal, then the swelling is truly improving. That makes sense. So OCT is very helpful.
Pediatric ophthalmology anytime, any quicker than anybody else. And so sometimes I send them to the optometrist because they can a lot of times do better. They can even take pictures now. But once you discover that they do have papilledema, is that like, do they need to go? Like they're stable, they're not vomiting, they're talking to you. It's just their complaints kind of follow the right story. Is that going to be like you need to go to the ER? Do you need to wait for a month for your clinic? What do you do next?
Yeah, if your suspicion, the question was if you have a high suspicion for pseudotumor from a pediatrician's office, what do you do next? So I think to expedite it, I think you can first definitely get an MRI for neuroimaging for the subsequent ophthalmologist or pedi ophthalmologist or neurologist. Because once we have all that MRI that rules out any structural lesion, then we can really proceed with the lumbar puncture. And because I think we're trying to rule out other stuff before we can actually start the Diamox or other treatments. So.
I never order MRIs myself, usually because I feel like if I'm going to order a test, I need to be able to interpret it, and I also need to know what the proper test is. And so I did see that you did say that if I'm going to order an MRI, in this instance, it sounds like I need to order it with and without contrast and with a venogram.
Correct. Yeah. So yeah, MRI brain with and without, and MR venograms. And that will really help expedite that sort of the workup. So like you mentioned, yeah, it's really hard. Unfortunately, there's limited of us. So yeah. Thank you.